Hello, and thank you for joining us today. We are ready to begin. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The speaker and planning committee members have disclosed no relevant financial relationships. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, we will have time for a question and answer session. You'll see on your GoToWebinar control panel that you can send a message through the questions feature. This is where you can type in any question you'd like to pose to our presenter. Be sure to hit send so the message makes it to us. We'd like to thank our speaker today for sharing her expertise. Our speaker today is Dr. Breckenridge. Dr. Breckenridge presently is the AACN Chief Nurse Administrator and the CABRN Approved Director to begin a new College of Nursing at Westcliff University, Irvine, California. She is the past president of Xi Chapter of University of Pennsylvania, Philadelphia, Pennsylvania, United States. She is a creator of nursing education, research, and practice, also known as the NERP model, based on neighborhood healthcare principles for nursing students to continue to meet clinical objectives at testing and vaccination sites during the COVID-19 pandemic. Dr. Breckenridge's main focus as a professor, dean, vice president, and chief nurse administrator is her long-term development of strategies for success program, focusing on diversity, equity, and inclusion of students' access to nursing education, retention, on-time graduation, passing licensure, and certification exams to join the nursing workforce as culturally competent nurses. We are so glad to have you today, and welcome.
Well, thank you, Linda Andrews. I want to thank you very much, and also for Megan LaGreco for working with us for this presentation. I also want to welcome all the nurses throughout the United States and the globe. That is the one reason I just think Sigma International is so important to all of us, that we can all come together, whether we are working or between positions, we are moving forward in our education, or if a nurse has chosen to not be in nursing at that time for whatever reason, but they can still be a member and they can be a part of Sigma International. And lastly, we always have a place to say, we know someone, even if we're in another country, or if those colleagues come here to the United States. So I want to thank everyone at Sigma, and I want to welcome all of you and thank you for being here with us today. When we look at today's presentation and we look at the topic that this webinar, we will discuss the history of vaccinations, beginning with the 1918 Spanish flu pandemic and ending with the COVID-19 pandemic. But we know that's not over yet, and we're still working on this situation. We will discuss best practices to address vaccination hesitancy, along with other epidemiological principles, such as herd immunity. So when we look at the learning objectives, the first one being that participants, yourself, will identify the similar characteristics of the 1918 pandemic, of the Spanish flu, to present day with the COVID-19 pandemic. We'll begin there, and then we'll move onward to identify the best practices to address vaccination hesitancy, and then lastly, to discuss other epidemiological principles such as herd immunity. So when we move into the similarities of the 1918 Spanish flu pandemic and look at the similarities today of 2020 COVID pandemic, we look forward to the different outcomes, discussing the history of vaccinations, the measurable components, and then you want to also be able to list at least one similarity. When we look at the overall objectives, we think in terms of more than 200,000 have died by March of this year. The cities in lockdown, vaccination trials underway. We think in terms of the holiday message that has been sent. See that Thanksgiving celebrations are restricted as much as possible so as to prevent another flare-up. And then we move forward to, this isn't the message of Thanksgiving 2020. It was the Thanksgiving Day notice that ran in the Omaha World Herald on November 28th, 1918, when Americans found themselves in a similar predicament to the millions now that are grappling with how to celebrate the holiday seasons amid, even today, the coronavirus pandemic. So the message was then, here's how we did it. In 1918, the officials warned people to stay home for the holidays. The first cases were in March of 1918, and many of us were sent from our schools of nursing and told start to go online. Ours was March 17th that we were starting to pack up. The second wave was October 1918, back with the Spanish flu, and we had a wave also. The third wave was January 1919, and we know how the waves not only stopped there, but continued. By the end of November 1918, the United States was in the midst of the suffrage movement. It was also the ending of World War I. And at that time, they were battling the second wave of the H1N1 influenza epidemic, known as the Spanish flu. The first cases were detected in the United States previously in March 1918, growing exponentially by the fall. In October, the virus burned through the nation. Dozens of cities implemented face mask orders and curfews and lockdowns for 2 to 3 weeks, closing the schools, the libraries, the theaters, the movie houses, dance halls, churches, ice cream parlors, and soda shops. The virus killed about 195,000 Americans during October alone, back in those days. So we move forward then to the vaccination science that was occurring back in 1918, as we hear all about our vaccination science today. But back in 1918, the vaccine that was made during the pandemic was a vaccine against bacteria, which they thought was the cause of influenza. So not only were vaccines of this era crude and not all that effective, but the vaccine also that they did produce was for the wrong organism. Vaccine Science was nowhere near the scientific advancements we have today in 2020 and even today in 2022. The study of virology was in its infancy, and researchers didn't have the tools to see viruses. Bacteria was much larger and could be viewed under a light microscope, but viruses require electronic microscopic instrumentation, and that had not been invented at that time. And this comes from Markel, who has an excellent resource in this area. The vaccines that the researchers developed did not stop the impending third wave of the Spanish flu. As we move then, by January 1919, the USA was fully engulfed in the third wave of influenza and throughout the globe at that time. The virus spread throughout the winter and spring, killing thousands more. It infected 1/3 of the world's population and killed approximately 675,000 Americans. Flu didn't stop circulating. The question was, when did people go out and get exposed to it? And that's what's going on in 2020, went on, even today in 2022. A century later, the nation has recorded more than 12 million cases of COVID-19 and more than 255,000 people in the USA have died. Dozens of states re-implemented coronavirus-related restrictions, and health officials echo the stay-at-home guidance issued decades ago. If history tells us anything, it is the risk of contracting the virus or spreading the virus by congregating in groups or even traditional holiday parties is right now too great. Now, this is what people have to make the decisions on. So as we move forward with a polling vaccine effectiveness to review with the general public as evidence when the vaccine hesitancy occurs. So when you're thinking about this polling, you want to think about the several studies of vaccine effectiveness have been conducted in the UK against the different COVID-19 variants, and the vaccine effectiveness against symptomatic disease with the Omicron variant is substantially lower than against the Delta variant, with rapid waning. However, protection against the hospital remain high, particularly after 3 doses. So again, the poll itself is asking to look at then the effectiveness. Is it true? Is it false? Is it not a situation where you're not sure? And I'm definitely seeing true here. Because we're talking about evidence-based practice. We're talking about the evidence that as nurses, and those that are not nurses, if they are also on, that is the practice of our health care, not just in the United States, but throughout the globe. So thank you for your responses. So when we do look at vaccinated versus not vaccinated, the weekly average, the deaths per 100,000 from October to November 2021, and we're seeing even more information, even as of today from the CDC. But the unvaccinated are definitely at the higher realm of this situation, where there's a definite increase in deaths. And this is very troubling to many of us nurses or healthcare providers, because we want people to realize right now there is a vaccine. And when you look at the vaccination, and it's 2 doses with no booster, It's at 0.6, the level of deaths. And when you look at with the booster, that's 0.1. And therefore, when we look at the evidence, that is what is being brought forth every day. And just this morning, when I was looking at what the CDC is saying, they are saying that if one is double vaccinated as well as boosted, 95% will be able to not face, because of coronavirus, this is a situation of death. And that's something that we really need to keep thinking about and moving forward with that knowledge base. So as we move forward, we want to look into then the major antidote to decrease the vaccination hesitancy. And when you're thinking about this question of true, false, or not, sure, you want to think in terms of that for the pandemic-weary Americans who got their COVID-19 shot at the first opportunity, vaccine hesitancy has become increasingly difficult for many to understand. For social and behavioral scientists, and this is where this came from, Rubella, the reasons are clear. As the scientist says, the one word is truth. So is this true? Is this false? Or is this not true? And then also, what are the words that you are coming up with as the major anecdote? And I see that's already coming up. And the reference that I just gave is reference, by the way. And there's many other words. Trust is one of the words. But there's togetherness. We're seeing knowledge. It's right in the center. I think that's terrific too. There's also the facts. There's hope. There's care. There's consistency. There's togetherness, understanding, persistence. But as we can see, knowledge and education are the two largest here. And most of us are educators. But if we're not educators, we come from a college, usually that has a Sigma chapter. So we are thinking in terms of knowledge, we're thinking in terms of education, and that literacy is coming up also here. Thank you. It's really terrific. And this will be sent out with the material, so you have it. So the antidote to vaccine hesitancy. The scientist that I just brought forth, LeMay, has even said we need to think about the pre-bunking, the inoculation, and other best practices in health communication. And as I said before about the pandemic-weary Americans, this is what this scientist has been very clear about, that believing trust is one of the major reasons of the hesitancy. And that, again, this Dr. LeMay, PhD and Masters of Public Health, really has been looking at then the roots of vaccine hesitancy, how she actually responds to it, and how we can prevent it from flourishing. And I did want to go outside of just nursing to see what others were thinking in terms of. And that is why I chose the work of Dr. LeMay. I'd like to move forward with then a few other statements related to vaccine hesitancy. So the next slide brings up then the age, social determinants of health associated with COVID-19, vaccine hesitancy in southern United States. And across the United States, There is systemic racism as well as economic marginalization that have contributed to the disproportionate impact of COVID-19 in African American communities. These and other social determinants of health have made the most effective practices for mitigating the impact of COVID-19, such as social distancing, working from home, and vaccination, less accessible in African American communities than in many others. And this piece of information comes from the recent funded study that investigators analyzed attitudes related to COVID-19 vaccination among 257 community dwelling members from the central Savannah River area who were 18 years of age or older, of which 97% identified as African American. Investigators identified several social determinants of health associated with vaccine hesitancy. They hope their findings will help guide public health efforts to build trust in communities experiencing COVID-19 related health disparities throughout the U.S. So from this, what do you see as the biggest drivers of vaccine hesitancy? And there were the three that were brought forth. The first, the development of the COVID-19 vaccination. The development was very quick. The vaccine has been out for a very short period of time, and long-term effects have not been adequately studied, is what is said over and over, even though it has passed, and they have passed the different vaccines, the FDA. And the amount of work that was put into the decisions was rapid, but we need to keep in mind it was done at an emergency level, and it was done with the rigor that was necessary for approval. Then there's the second one, autonomy and liberty. And think about all of the non-pharmaceutical interventions we promoted, where people have said, you can't tell me to wear a mask. You can't tell me to stay at home. Think about the vaccines that are another intervention where people say, you can't tell me what to do. I have autonomy over my body. And these are the type of statements that do cause those that say, I cannot take the vaccine. Then there's the third, the misinformation and disinformation. Early August, when mask guidelines changed again, public health saw that this was a part of the scientific process of gathering data, analyzing that data, and then using that data to make decisions. The public does not see it that way. They see it that the public health scientists not knowing what they're doing. And that has been fueled by a lot of misinformation, which has been rampant on social media. Other epidemiological principles, including herd immunity, also need to be addressed. Currently, 99% of all vaccines used in Africa are imported. But over the last year, organizations including the World Health Organization, African Centers for the Disease Control and Prevention, known as the Africa CDC, and partners have developed plans to manufacture the doses locally. This will be a crucial step toward greater vaccine equity and pandemic preparations. And this is very important for us to think about what the other countries are doing here in the United States and other countries are thinking about as they look at the United States, so that we are all in this together and we're understanding what the other countries are doing and they are understanding what we here in the United States are doing. So what do epidemiological, or epidemiologists, I should say, mean when they bring forth about herd immunity? What does that actually mean? Most of the population is immune to an infectious disease. This produces indirect protection, and it's also called immunity or population immunity, herd immunity, or population protection to those who are not immune to the disease. So currently, let's look at one of our other vaccination situations, and that would be the measles, mumps, and rubella, whereby over 90% of all children in the United States are vaccinated by their second birthday. This level of vaccination produces protection to the population as a whole, even to those who aren't vaccinated, by decreasing the viral circulation and the chance someone who is unvaccinated will encounter the virus. So when we move to a major statement here about the measles, mumps, and rubella vaccination, we think in terms of then, if a person with measles were to come to the United States, for example, 9 out of every 10 people, that person would or could infect, would be immune, making it very hard for measles to spread in the population. As a result, even though we still see localized outbreaks of measles in the United States, those outbreaks generally die down without starting any type of a nationwide epidemic. So when we think in terms of, is herd immunity still an achievable goal for COVID-19? It is. Yes, it is. COVID-19 can move to herd immunity, but it will not achieve this level of immunity soon in the population. It will not achieve the level that the measles with the mumps and rubella vaccine achieved. Returning to the life as it was before the pandemic without seeing large coronavirus outbreaks is unlikely to happen for several years. And this is for the following 3 reasons. It has been much harder to get people vaccinated against COVID-19 than against measles. As of September 2021, just over half of the United States population was fully vaccinated against COVID-19. Even though we know that the FDA-approved vaccines are extremely safe and have remained highly effective, even against new variants like the Delta variant and now the Omicron variant, and now we are looking at this variant, which is a subvariant of Omicron. So now we look at the second reason. Young children are still not eligible for the vaccine, and new children are born every day. So until we get vaccines that are approved for use in all ages, there is going to be ongoing transmission of the coronavirus in children who will in turn be able to infect adults, especially unvaccinated ones. Now, we are hearing that within the next couple of weeks, we might be able to go under 5 years of age, and that could happen any day. So we heard a lot about it yesterday and the day before, that it is imminent. It should happen within a week or two. And this is one of the directions that the science is trying to move. And third, while vaccines against COVID-19 are very effective and dramatically reduce the risk of infection, they do not reduce that risk to zero. People who have gotten vaccinated can still become infected, breakthrough infections. And some people who have had COVID-19 can get it again. This means the need for an even higher level of vaccination against COVID-19 to achieve herd immunity. And we do recognize the fact that, yes, our population throughout the globe can be fully vaccinated and boosted and have a breakthrough. But we've already discussed the difference related to that moving forward to death from coronavirus, that it is very, very low if someone is double vaccinated as well as boosted. So when we look at COVID vaccine facts for nurses, many of this has been provided by Johnson & Johnson and many other associations, as well as the misinformation materials from Sigma. We need to look first at Watch Now, COVID vaccines, ethical considerations for nurses. And these all take time, but we've got a few amounts of time so that you have an idea how much time to put aside if you need to do so. So 41 minutes for that one. Get the facts, have a conversation, read about it, the cost of waiting. And this, I think, is a very important one for those that are facing quite a few situations with vaccine hesitancy. Also, watch 8 things you need to know about COVID-19 booster. And then learn more. NIH Community Engagement Alliance, the CEAL. Then there's more facts for nurses. The American Association of Critical Care Nurses did the Hear Us Out. And that's a national campaign to share with the public nurses' experiences on the front lines and to encourage vaccination. So our most popular webinar is also known as Watch This Informative Webinar about engaging with those that are vaccine hesitant. That's what they think is one of the best ones. 60 minutes. And this addresses how to have conversations with those that are vaccine hesitant and best practices. So all of those words that were brought forth would be areas that could be addressed in this one, as well as some of the other areas that I just brought up from Johnson & Johnson and the other associations. Now, because the majority of us are attached to a college or a university, whether we went to school there, whether we still teach there, whether we are active in our Sigma chapters, we really want to know about the colleges and what is occurring. And as you can see here, this table, and I have the reference there too, this table shows that in the United States, 1,033 colleges are requiring students and employees to be vaccinated against COVID-19. So keep in mind that this is an area that we are still working with. Every day we are hearing about the mask dates, making sure someone is pre-screened before they come into the class, and that they also have the COVID vaccination and booster requirements. And this brings me to the NERP model, the Nursing Education Research and Practice model. That at this time, when I developed this model with my team, our students, and others, I was the dean of Mervyn M. Dimley School of Nursing at Charles R. Drew University in Los Angeles. And it was in March, as I said, we were asked to start to think about moving off campus of 2020. But it was before that, approximately 3 weeks before that, that we were all saying, how can we move forward? And because we were on learning management systems, we made sure everyone was ready to go to teach remotely. We did that very effectively. I'm very proud of my whole team. Did a great job. When we moved forward then, we had to think about the state of emergency. And it was our governor in California that said the state of emergency for an increased healthcare core of nursing, medical, and other healthcare students to volunteer and coordinate clinical hour requirements to progress in their programs of study, graduate on time, and join the healthcare workforce during this pandemic. And having had a background where I was able to work with neighborhood health centers, nursing neighborhood health centers back in the Philadelphia area, I really thought in terms of those neighborhood health centers and how could we therefore have the students be at those centers. And I was also asked, would this be possible? And yes, and the team worked so hard to make this possible. And what we did is we added all the hours up. We made sure the objectives met the areas of the coursework that the students needed. And I'm just going to give one example. And there were many. But making sure when we called them the neighbors because they were from our neighborhood. When they came for their testing, we would have the students and the faculty would be assessing if they needed food, if they have food scarcity. And therefore they could go to the pantry that that testing site had and bring some food to that family or to that person who came through. Many came in cars, but many even walked from the neighborhood. And this was an area that was so important that we were engaged in making sure that the neighbors that came were not only tested and then it moved into vaccination, but also their assessment of their wellness. And as we moved forward, and we still are in many of the COVID sites throughout all of our areas, our students are making such a difference, and our faculty and our nurses. So at this time, if there are any questions that I can handle right now, or we can email back to anyone who has any questions, that is fine, because we want to thank you for attending, and we definitely want your feedback, so thank you.
This has been extremely informative, so thank you for all of that. We do have some questions in the chat, and so just as a reminder, if you do have questions for Dr. Breckenridge, please utilize the questions feature and we can relay those questions to her. One question is from the country of Oman, and we have a nurse that did a qualitative study about the COVID-19 vaccine, and majority of participants had vaccine hesitancy due to contradicting information. Her question is about what the mortality rate under the age of 5 is due to COVID-19. Do you happen to know any of those pediatric statistics?
Okay, well, we know in the United States right now a large increase of young children are in the hospital. That is a group that has, I'm going to use the word exponentially, has increased. So we do know that. As far as the mortality, we do know, which we are fortunate at this point, that it is still low. That it's low. As far as the exact number, we can definitely get that for you and email that to make sure you use my email or the Sigma email. So again, the key here is, I would say from the evidence that is out there, and I am fortunate in one of my advisory boards that I even have right now, we had a representative from the Children's Hospital, and I have worked with the CNO at another children's hospital in Los Angeles, as well as back when I was in the Philadelphia area. We worked very closely with the children's hospital. So I'm going to use the evidence related to our young children. It's seeming to occur the same approach with our adults. When one is vaccinated, we've talked about the death rate, but we also have to think about the hospitalization. There's definitely a significant decrease in hospitalizations of those that are double vaccinated, that are adults, as well as boosted. And with children that are of the age where they can be vaccinated, there is showing definitely a decrease in the number of children going into the hospital also. So again, it is following suit. That's why they're so concerned about making sure the 5 and under children are also vaccinated. So I hope that helps. I think the key here is we have a science that has shown that we have the evidence of safe vaccinations. The reason there's a hold on the 5 and under is that there still has to be the approval, the rigor at the level for approval. And we do know that I gave one example being the measles, but there's others such as polio and many others that we can go over related to when the vaccination has been approved by the FDA or by the countries through their appropriate sources. They are effective, and they're effective at the level of what we're trying to make sure it does not happen. Going into the hospital to the point of needing ICU care and facing death.
Thank you for yeah, that was a great answer. Thank you for that answer. And I would encourage, just like Dr. Breckenridge said, if you want to continue the conversation, to go ahead and shoot her an email at the email you see on the screen. And I'm sure she would love to dialogue with you when about all these topics. We do have a question that I think has come up several times, especially amongst us as nurses, in regards to are there any studies about breastfeeding and protection passed to the newborn of a woman who has been vaccinated? What do you think about that?
Okay. Now, again, I will only go by what is out there in the evidence because I am not myself let's say, educated beyond the beginning levels and having children myself in OB. So keep that in mind. So I would like to say that we can get back related to any specifics, so we could even add that in when we send out this webinar. Linda, I think that would be a good idea because, again, there is much concern here about the breastfeeding situation. But right now, it has been that all of the adults should be vaccinated. That is what's in the literature. So again, if you're really concerned related specifically, then we can see if there's anything that's against that belief system. But I've seen more concern. The words are concern, I'm going to say. Is it okay? But the science is saying all adults should be vaccinated. That is what has come forth. And that naturally you want the woman to go to their physician or their healthcare provider, because it could be a nurse practitioner, who will let them know if they feel it is the right thing for them to do. That's the best way to handle that, for sure.
Great. Thank you so much for that. We have a question from a new nurse. And so she is asking specifically for some advice on how to educate patients that are at risk but are hesitant to get the vaccine. Do you have any words of wisdom to share with this new nurse?
Absolutely. I think that the more we have the patients, our neighbors, our clients see the others who are stating, I should have been vaccinated, while they are in an ICU setting, while they have the mask on them and they're gasping for breath. I think that is probably even more effective than jabbing someone with a needle. And I know all the politicians got up and showed how they were jabbed with a needle and they got their shot, they called it, on those things. I think the less we just show the needle and we give the subjective anecdotes, and when I say subjective, their own opinion about why they shouldn't have waited, that's going to be the most effective. They're the perceptions of the patients that they can, I think, identify with. And I think that has been shown as the best approach in the literature at this time. So I think that we have more studies like this, and I think that's why we have to look at some of the other work that's out there, like I presented here, about that trust, the discussions with people, their perceptions. And one of the works that I've done through the years is perception work. And one of the nurse theorists believes in what's the patient's perception, the neighbor's perception, the person's perception, the student's perception, and then what is the objective assessment of the healthcare provider, being us as nurses. And that would be the objective side. So what we want to do, and yourself as a new nurse, you want to think in terms of what's the patient's perception, but then here's the evidence. And we have to do that in a very caring, a very compassionate, a non-threatening approach, so that the patients understand, the neighbors understand, we're here for them, and we have to gain their trust. So I hope that helps. And I think a lot of these facts for nurses will definitely help.
Perfect. Thank you. We do have a question that goes back actually to the very beginning of your presentation when you were first talking about the 1918 flu.
Yeah.
How effective were the 1918 lockdowns and mask mandates in controlling the spread of the flu?
Okay, well, thank you very much. This is very dear to my heart. I'm from Philadelphia. That was the epicenter. Philadelphia was the epicenter because they agreed to have the Liberty Parade, which just made everything even worse in Philadelphia. My own father's parents, they did die of the flu, but it was pneumonia. And that's why most people did die. It was from the double pneumonia. And his mother died during the childbirth of him, and the father 6 weeks later. And there's no graves for either one of them because they're in the mass graves. So again, when we talk about how severe it was extremely severe. And even though we talk about 3 waves, and you see in the literature the 1919, it went on longer until they had vaccinations. Not until they had vaccinations was it totally at a level where it would have been where herd immunity is. So again, it was, when you talk about what was the most effective, St. Louis at that time didn't allow parades, got a handle over it right away, and they did very well. So there are, and in the references I have, you will see the different cities and which ones did the best. Actually, it was San Francisco that moved forward with a major, major rebellion against masks. And they didn't do well because they didn't agree with masks. So again, we are seeing 100 years later, but again, they did not have the abilities to use, and I should say produce, a vaccine that would work. Yeah. And I'd like to say one last thing when it comes up. That is why when this came forth, I was actually sent to where they thought the first patient with coronavirus was in South Los Angeles, and they sent me there to the town hall to hear it. And when on the way back, I said it wasn't the first patient, by the way. It was not found there. It was misinformation. But it turns out on my way back, I said to myself, as soon as I get back, I want to say to the faculty, and I said this to the president of the university at the time, as well as the provost, we need to right away read about the Spanish flu. And we need to make sure we proceed so that we do not make the same errors and that we work right away because of what occurred. Because I had studied the Spanish flu so much, being from Philadelphia and having family that were a part of the situation.
I want to thank you for your honesty and transparency with all of these global attendees today about your family and what that looks like and your personal connection to it. So thank you for that. We have many questions in the questions feature regarding the continued conversation about vaccine hesitancy, how the booster quote unquote isn't FDA approved and it being experimental, but also, Diane, do you have anything you want to say about nurses in the field that are hesitant to get the vaccine? And we have just a few minutes left, so anything you want to speak about in that regard?
Well, talk about personal reasons again. I did, in my day, I did wind up with pneumonia after having the measles, by the way. And we had no health insurance, my family, because my dad was on strike. He worked at a factory and they were on strike, so there was no health insurance. And the young boy on my street went to the hospital and he passed away. But my parents took care of me in the home and they were with me all the time. And it turns out that, again, the minute the vaccination came out, we were right there. And maybe because we had so much family situations due to the Spanish flu, and then my situation, that's why I'm so passionate about this. And the nurses that are out there, we know everyone means well. We know the nurses mean well. We know the patients who are concerned, the neighbors who are concerned about being vaccinated. But the science is there. And the evidence right now with the booster showing that it even brings one up to 95%. So you can imagine when it came out, I was right there. I'm just going to let you know that. Then I was allowed in my age group and in my care for people, because I'm not right on the front lines, then I was where I was in the right line to be vaccinated and then boosted. So I do believe that we need to work very closely with our people who are worried about vaccinations. And I had 3 students who were very concerned, and they actually did literature searches. They did an excellent job. They looked into all of the literature related to anaphylactic shock from the vaccination. And of the thousands and then millions of people, when they looked into it and they wrote it all down, they came back and we went over everything. And they gave presentations. They did, like I said, a great job. It was under a grant, by the way, that someone at the university had. And they did their posters. And they showed that those that had anaphylactic shock was very minimal. And if they stayed the 20 minutes at the site, it was reversed, and they all survived due to the vaccination and the anaphylactic shock. Now, we do know there's situations out there, and when it's looked into, there's secondary reasons and illnesses that factor in. So again, when we're in a public health crisis, which we are in, we need to look at it as a public health, and how can we all work together and make sure we're all safe and the right thing is done, not only just for us, but for our elderly, for our little children, for our babies that are being born that can't be vaccinated at this time, and then keep working with the science. And then how do we make sure that we're getting the right information instead of any kind of wrong information? And my heart goes out to all that are very concerned, and I understand that. And like you said, Linda, I'm probably much more passionate, and I'm sure others are, when they had any family situation. And we all know there's going to be that even today with some of our families, whether they've had somebody who had a vaccination and they thought something went wrong. And I'm going to share one more thing. I had very strong side effects after the second vaccination, just so you know. But I would still take it again. And the reason I would do so is because I think that is the right thing to do. So that is now a personal statement.
Thank you for sharing all of that. Do you think if I gave you one more question, you could maybe
Sure,
give it a shot? Because
I'm fine.
this is something that I've seen and heard in my nursing group, network. And so a question posed in the chat is about the risk for myocarditis in young men that get the vaccine. This is a concern of many families. Do you know anything about the risk for myocarditis?
This has come up in the literature, you're absolutely right. And I do think it goes back to, again, if there's any concern, the person should be directed to work with their healthcare provider. Now, if for some reason they have a high copay, they can't get in the door, then I think as advocates for our patients, our families, our neighbors, whoever we're working with, we then have to determine what hospital is nearby that can give them that information. And I know that a few of the hospitals right down the street from where I am, right here in Los Angeles, they do that. You can go in, they have an area where they will have one of the physicians or nurse practitioners or one of the research scientists, if it's a research center, speak to people and go over it. So again, I think for any reason, if someone is concerned, such as with the myocarditis for the gentleman, that we definitely have to have them go to their healthcare provider to make sure they feel it's the right thing for them. The usual is to go ahead with the vaccination. But again, I would get the medical advice or the healthcare provider advice.
Yeah, I think I agree with you in regards to the literature and all the research, Diane. I think it actually is more likely that young men, and this is, please don't quote me on this. I would direct you to the literature, but young men are actually more likely to get myocarditis if they contract COVID than have myocarditis as a COVID vaccine side effect.
Right.
But I would love to dialogue with anyone that wants to chat about that. And also, Diane, unfortunately, we weren't able to get to all the questions in that were posed. So once again, Diane has her contact information on the screen here. And please feel free to email us with any questions or any further conversations you want to have in regards to COVID-19 and the vaccines. We want to thank you all so much for joining us today for all of this great information. Sigma is very grateful to Dr. Breckenridge for sharing with the audience, and we definitely look forward to hearing more from you in the future. We've enjoyed this webinar, and as a reminder, 1 week from today, you will be emailed the link to the evaluation for you to obtain your Nursing Continuing Professional Development Certificate. Be sure to check out Sigma's upcoming webinars and resources to support you and your colleagues at sigmanursing.org. Also, previously recorded webinars are freely available on the Sigma repository. Thank you for joining us today and have a wonderful day.
Thank you.